So we're going to talk about chest tube assessment and what do you assess when you have a patient with a chest tube. So what do you think the very first thing is that you're going to assess when you have a patient with a chest tube? Typically at this point, I'm going to assess bubbling. I'm going to assess the suction. I'm going to assess the tube. And all of those would be things that you'll want to assess, but not the very first thing. So the very first thing you're going to assess when you have a patient with a chest tube is your patient. Chest tubes are intimidating, but they are, in a sense, just a drain. So you don't want to forget that there is a patient attached to the end of that drain. So the very first thing you're going to assess when you have a patient with a chest tube is, are they breathing? How are they doing? Because that chest tube is going into the pleural cavity and it's draining either fluid, blood, or air, or a combo of all of that. So it's going into the pleural cavity. My main concern is going to be their respiratory status. So as I'm walking into the room, I can already assess to see if that patient is in any kind of respiratory distress. So signs of respiratory distress that you would look for. Yeah, what do you think? I'm going to be looking at that patient and I'm going, do they have any nasal flaring? Are they pursed-lipped breathing? Do they have retractions? Are they cyanotic? Are they visibly short of breath? Are they visibly anxious? Are they tripoding? When I go and extend my hand to say, hi, how are you? Can they carry on a conversation with me? If they can't, all of those things are signs of respiratory distress and could indicate that there's an issue with the drain that's in the pleural cavity. So I've come in and I've assessed my patient to make sure that they aren't in any kind of respiratory distress. The next thing that I quickly glance at is I always want to make sure that my connection is taped and secure before I start messing with the tube. Okay, so after I've looked quickly, I haven't really assessed it, I'm just making sure that it is taped. I'm going to start at the patient and we're going to work our way towards the drain because my main concern is the patient. The first thing I'm going to look at is I'm looking first. So I'm looking to see, is my dressing taped on all four sides? Now, here I have it taped in blue so that you can visibly see that it's on four sides of the chest tube. But in real life, it's normally that thick white tape and it covers the entire dressing. It doesn't, you have just sheets of that thick white tape. The dressing should be taped on four sides. Now I know what you learned for ATI is that it's supposed to be taped on three. Taped on three sides if there was an emergency and that chest tube fell out. So if the chest tube has been displaced, that tube fell out, and I had those thick pieces of white tape going across, I would lift up one side so that I wouldn't get a tension pneumo. Okay, so if everything's all good, this chest tube is in place, I'm looking to see, is my dressing taped on all four sides? The next thing I'm looking for is I'm looking to see, is there any kind of drainage? If there is drainage, I'm going to take a Sharpie and I'm going to outline exactly how that drainage is. And then I'm going to put the date and the time so that if somebody who's coming in on the next shift can look at it and go, oh yeah, okay, that's about the same amount of drainage, or did it grow? So after I've looked at it, now I'm going to feel it. So I'm palpating lightly and I'm feeling for any subcutaneous emphysema. Now, subcutaneous emphysema, when you guys come back out to the sim lab, I want you guys to feel this. It feels like Rice Krispies under the skin, okay? It truly does. Feels like Rice Krispies under the skin. It sounds like crepitus, but it feels like Rice Krispies, so we call it subcutaneous emphysema. Now, notice when I was palpating, I was not digging my fingers into the chest, kind of finding out if they have subcutaneous emphysema. That's not what you do. You just lightly palpate, and yes, you can feel that subcutaneous emphysema underneath the skin. Now, subcutaneous emphysema means that there's air that's leaked in underneath the skin. You can have that during insertion. It can actually happen during the chest tube insertion. So that would be something that if the chest tube was just placed in the OR or the ER, you'd want to know and palpate and examine that. So you'd be like, oh, okay, that was there from insertion. So you can pass that on and report. Or is it something new? If it's something new, you need to let the physician know. Even if it happened during insertion, you probably need to let the physician know so that he is aware that there was subcutaneous emphysema. So palpated for subcutaneous emphysema, and now I'm moving my way down. First thing I'm going to come to is I'm going to come to the connection. Now the connection, is connecting the chest tube to this drainage tube. It should be, per your ATI, taped in a spiral fashion. Basically, we just want to make sure that the chest tube and the tube are connected, and that there is a continuous piece of tape going across, and that it is somewhere that you can peel it back if I needed to change out this tube. Okay? I'm then going to, oops, there goes my chest tube. So what do I need to do? Undo one side. Okay. So on my chest tube, I've done my site here. I'm now going to trace my tube. And what I'm tracing it for is I need to make sure I don't have what we call dependent loops. Now, dependent loops are anytime you have something going to gravity that then has to go uphill to then go downhill. So you can have them with Foley's. You can have them with the chest tube. Notice the drainage is down, and typically you'll see it when it's going up and over a guardrail. So if you have a dependent loop, you just want to move that tube so you don't have that dependent loop anymore. I'm going to continue to trace my tube. And what I'm looking for is I'm looking at the type of drainage that I have. Okay. I'm looking to see, are there any clots or kinks? And then the next thing I'm looking for is my clamp. We never clamp a chest tube unless we A, have a doctor's order, or B, we're changing out this atrium. But I need to know that the clamp is there, because if something happens to this tube, I need to be able to clamp it in an emergency so that a bunch of air doesn't go rushing into my patient. The next thing we're going to look at is going to be the drainage system. Drainage system should never be lifted above the level of the chest, but I'm going to put it up on here on the stool so that we have a better view for the video. Okay, so let's take a look at the drainage system. Now, looking at the drainage system, we have basically, we've got 4 chambers. So this first chamber here is your suction control chamber. And the suction control chamber is dictated by how much the doctor has ordered. They'll order 20 centimeters, they'll order 15, but typically it's 20. You have this dial right here at the very back, the dial that we use when you are filling up the chest tube that can adjust how much bubbling is in there. Okay, so one of the questions you're going to get asked is, which do you think is pulling more fluid from my patient? Right now, with this amount of bubbling, or now with this much bubbling? Most people think that this amount of bubbling is going to pull more from my patient than that amount of bubbling. And the truth is, pulling the same amount. All you need in this chamber is a low, gentle roll. And with the low, gentle roll, you'll actually pull by number of centimeters of water, not by how vigorously the water is bubbling. The only thing that happens when you have this vigorous and bubbling is that it makes your water evaporate faster and it irritates. The next chamber we're going to look at is chamber C. Chamber C is your water seal. Now, in your water seal, you should have 2 centimeters of water, okay? And then you have this little ball here, and that little ball rises and falls with inspiration, okay? It should be rising between 0, +1, and +2. That ball rising up and down is called tidling, okay? So every time the patient breathes, that ball is going to move up. There are a couple of reasons why that ball might not move. So the first one and most obvious is your patient is breathing. If this little ball not moving was the first thing that indicates to you that your patient wasn't breathing, then we have a few issues. You missed something on your assessment. The other reason that that ball might not move, it could not be moving because there is a clot, a kink, or your clamp is on, and so we're not seeing the ball. Little ball can't measure the change in intrathoracic pressure. Or the third reason could be that the chest is healed and the chest tube is ready to be removed. Now, the little ball should be between 0, +1, and +2. If it rises above 0, this here measures intrathoracic pressure. So if it rises above 0, that is a call to your RT and to your physician. There is nothing from a nursing standpoint that we can do at here. There should never be any bubbling in chamber C. Okay, so chamber C should look just like this with no bubbling. If you have continuous bubbling in chamber C, that tells us that we have an air leak. And that's why we've gone and we've checked, do I have subcutaneous emphysema? Is my connection taped? Is my atrium cracked at all? So I'm looking to see what is the cause of this continuous bubbling. Now, if you have a huge pneumothorax, a bunch of air in the chest, you can occasionally get bubbling when the patient exhales. This is not what we normally see. What we tell everybody is there should never be any bubbling in chamber C. And if there is, you need to go find somebody who is more experienced than you to make the problem solve. And then the last thing we're going to look at is the collection chamber. So the collection chamber starts on this side. It will fill all the way up here and then overflow and start filling up this side. So this side should only be filled once this side is 100% filled. What you'll typically see though is that this side filled up and then this got knocked over, and we have some over here as well as some here. That's okay as long as you can still accurately measure how much fluid is being put out of your chest. And as long as you don't have an air leak, as long as the atrium is still intact and I can still clearly mark what line is mine versus what line was Ms. Cameron during our shift change, then it's okay. But if you've already got lines going all the way up here and you've taken up every room and you're going, I can't accurately count or see where my line is, then you might need to change out the atrium. So you want to look to see, make sure that the atrium is intact, and then you'll want to make sure that you've marked with date and time where your drainage is. The very last thing we're going to look at is up here on the wall, and it could be in the green to low wall. Thank you.